We have discussed almost all the inhaled anesthetics, only nitrous oxide is left behind. So today I will discuss nitrous oxide and then we will go towards intravenous general anesthetics. Nitrous oxide, it is the colorless inorganic gas. It is non-inflammable, non-irritating. It has low potency. Um, it has high minimum alveolar concentration. It has so it has got low potency. Its MAC value is almost about 105%. Its blood gas coefficient is very low. It is not soluble in blood. So it has rapid rate of induction as well as uh, rapid rate of recovery. It is very potent analgesic. So it can be used as a carrier for other anesthetics. It can be used as a single agent, usually with oxygen in dental extraction and in obstetrics. It is called as a laughing gas because it produces the signs of euphoria, sedation, and calm. It relieves the anxiety. So it can be used as for abusive purpose, like for recreational purpose. It has rapid onset and rapid recovery. It does not depress the respiration, and it has no muscle relaxation property. In clinical uses, it can be used in dental surgery, in obstetrics. It can be used in refractory pain, in terminal illness. It can be used, and it is also used mostly in maintenance of anesthesia. It is the least hepatotoxic drug. Its side effects is that it is teratogenic, so it may be avoided in pregnancy. It can cause bone marrow depression. Nitrous oxide, diffusion hypoxia is related with nitrous oxide. Diffusion hypoxia, I have also explained earlier. It is a decrease in partial pressure of oxygen usually observed as when the patient is emerging from an inhalational anesthetic, where nitrous oxide was a component. As I already told you people that nitrous oxide is not soluble. It has very low blood solubility. It is not soluble in blood. So it has rapid rate of induction as well as rapid rate of recovery because its partial pressure raises very quickly. When the during recovery, when nitrous oxide distributes from other parts of the body to the blood, and from the blood to the alveoli, and from the alveoli to the outside of the body, and there is a sudden rapid release of insoluble nitrous oxide can displace the alveolar oxygen, which can result in hypoxia. So all patients should receive supplemental oxygen at the end of anesthesia and during the immediate recovery period. As it has very low blood solubility, so it has fast rate of recovery. When the during recovery phase, nitrous oxide it distributes from the other parts of the body to the blood, and from the blood to the alveoli, and from the alveoli to the outside of the body. And when it displays when it moves from the blood to the alveoli, it displays alveolar oxygen, which can result in hypoxia because there is sudden release of nitrous oxide from the blood to the alveoli, so it may cause the hypoxia. So all of the patients where nitrous oxide and anesthesia is used for maintenance, such patients should receive supplemental oxygen at the end of anesthesia and during the immediate recovery period. Nitrous oxide, another effect which is related to nitrous oxide, it is the beneficial effect of nitrous oxide. It is known as the second gas effect. It has fast rate of induction, so it can be used with other gases which has slow rate of induction. It can carry the other gas with it along with it, which is known as second gas effect. The ability of the large volume uptake of one gas to accelerate the rate of rise of alveolar partial pressure of the concurrently administered companion gas is known as the second gas effect. Like it can be given with halothane, which has slow rate of induction, and slow rate of recovery. So it can be given with halothane, which is highly blood soluble, and when it is given with halothane, it accelerate the rate of rise of the alveolar partial pressure of halothane and carry along the halothane gas with it. So the rate of induction of halothane will get fast. Now the advantages and disadvantages of nitrous oxide. Advantages are that they are it is non-inflammable and non-irritant. It has rapid induction and rapid recovery. It is very potent analgesic. It causes no nausea and vomiting. It is non-toxic to the liver, kidney, and brain. It has got the effect of second gas effect, which is beneficial. It is disadvantage is that it is not potent alone. It should be supplemented with other anesthetic agents. Its MAC value is very high. Hypoxia can occur with the use of nitrous oxide during recovery phase. It inhibits the methionine synthetase. Methionine synthetase is a precursor to DNA synthesis, so it can cause megaloblastic anemia. It also can inhibit vitamin B12 metabolism. It can be used recreationally. It is already told that it is laughing gas. It can cause the euphoria, sedation. Uh, Diffusion hypoxia is related with it. It is the disadvantage point for nitrous oxide. And next, we will cover the intravenous anesthetics. Intravenous anesthetics are usually used for induction only. They are used for the purpose of rapid induction. For maintenance, they are not usually used for maintenance. Maintenance can be done usually with inhaled anesthetic agents. Uh, they, sh- they are usually supplemented with analgesics and muscle relaxants. Now the classification inducing agents. First of all, these are the inducing agents. Inducing agents will inducing agents should be mostly done by thiopentone, methohexytone, sodium, propofol, etomidate, and then the slower agents. Slower agents should be used concurrently with general anesthetic. Slow agents include benzodiazepines. They are used to relieve the anxiety, perhaps most probably in pre-anesthetic medication. They can cause sedation. And next, the agents include ketamine, which produce dissociative anesthesia. Next agent is fentanyl, which will produce neuroleptic analgesia. So I will discuss one by one of all these agents. First of all, thiopentone sodium. Thiopentone sodium is a barbiturate. It's the ultra short acting redistribution occurs very quickly from the brain to the other body parts. Intravenous anesthetics, first agent is barbiturate or thiopental methoxytal. It's a potent anesthetic agent but a weak analgesic. It has high lipid solubility. It quickly enters the CNS and depress function, often in less than 1 minute, but redistribution occurs very rapidly as well to the other body tissues, including skeletal muscles and ultimately adipose tissue, which serve as a reservoir. All barbiturates can cause apnea, coughing, chest wall spasm, laryngospasm, and bronchospasm. Now, the disadvantages of thiopentone sodium is that it can cause pharyngeal and laryngeal reflexes persist. It can cause apnea. It can cause respiratory depression. It can cause hypotension. It is poor analgesic and muscle relaxant. Advantages of thiopentone include it gives rapid induction. It does not sensitize myocardium to adrenaline. It has no effect of vomiting and nausea. It is not explosive and non-irritant. It can be used for short operations. Other uses include it can be used in epilepsy, convulsions, or it can also be used in psychiatric patients. Next agent is propofol. Propofol is replacing thiopentone now because propofol has rapid induction. Uh, it has also rapid induction like thiopentone 15 to 45 seconds and lasts for 5 to 10 minutes. It has also rapid distribution. Distribution half-life is about 2 to 4 minutes. It has short elimination half-life, which is around about 100 minutes. Propofol, it's a phenol derivative. It is IV sedative hypnotic used in the induction or maintenance of anesthesia. Onset of action is smooth and rapid, round about 40 seconds. It decreases the blood pressure without depressing the myocardium. It also reduces the intracranial pressure. It is widely used and has replaced thiopentone as the first choice for anesthesia induction and sedation because it produces a euphoric feeling in the patient and it does not cause post-anesthetic nausea and vomiting. But its most common side effect is that it has poor analgesic, so it does not provide analgesia. Now the advantages and disadvantages of propofol. Advantages are that it has rapid induction. It does not sensitize myocardium to adrenaline. It has no nausea and vomiting affiliated with it. It is non-explosive and non-irritant. It can be used in short operations alone. Disadvantages is that it can cause induction apnea. It can cause hypotension. It can cause bradycardia. Dose-dependent respiratory depression may occur with the use of propofol. There may be It can cause pain during the injection. Next, IV anesthetic agent is ketamine. Ketamine is phencyclidine derivative. It can produce perhaps will, it will produce dissociative anesthesia. What is dissociative anesthesia? It is a state characterized by immobility, amnesia, and analgesia with light sleep and feeling of dissociation from the one's own body and mind and the surroundings. Site of action of ketamine is that it acts upon cortex and subcortical areas. It blocks NMDA receptors. Ketamine is a short-acting anesthetic agent. It induces a dissociated state in which the patient is unconscious but may appear to be awake, and he does not feel pain. This dissociative anesthesia produces sedation, amnesia, and immobility. Ketamine is also a potent bronchodilator. Therefore, it is beneficial in patients with asthmatics. Conversely, it is contraindicated in hypertensive or stroke patients because it can raise the blood pressure. Ketamine is used mainly in children and elderly adults for short procedures. It is not widely used because it increases cerebral blood flow and may induce hallucinations, particularly in young adults. Now, the uses of ketamine. It can be used in head and neck surgery. It can be used in asthmatic patients for surgery because it does not produce respiratory depression. It is bronchodilator. It can be used in short surgical procedures like burn dressing, forceps delivery, manual removal of placenta, and it's also can be used in certain procedures of dentistry. It can be used with diazepam, like in procedures like angiography, cardiac catheterization. It can be used in OPD surgical procedures. The disadvantages of ketamine is that it produces emergence phenomena in around about 50% of the patients, which include hypertension, increase in uh, intracranial pressure and intraocular pressure. It can it can cause uterine stimulation. It can produce the symptoms of psychosis and schizophrenia. It has poor muscle relaxation. It does not relax the muscle. Contraindications include glaucoma and hypertension. Fentanyl, next IV agent is fentanyl. It can produce neuroleptic analgesia along with droperidol. It is opioid analgesic. Duration of action is about 30 to 50 minutes. Clinical uses, it can be used in combination with diazepam, can be used in diagnostic, endoscopic, and angiographic procedures. It used in adjunct to spinal and nerve block anesthesia. Neuroleptic analgesia. What is neuroleptic analgesia? It is a state of analgesia and amnesia produced when fentanyl is used with droperidol and nitrous oxide. It is suitable for burn dressing and endoscopic examination. It is characterized by immobility, amnesia, and intense analgesia without total loss of consciousness. Now, the advantages and disadvantages of fentanyl. Advantages of fentanyl include smooth onset and rapid recovery. It suppresses the vomiting and coughing. It There is less fall in blood pressure and no sensitization to adrenaline with the use of fentanyl. Disadvantage is that it can cause respiratory depression. It increases the tone of chest muscle. Dexmedetomidine. It is a sedative used mostly in intensive care settings and surgery. It is relatively unique in its ability to provide sedation without respiratory depression. Like clonidine, it is an alpha 2 receptor agonist in certain parts of the brain. Dexmedetomidine has sedative, analgesic, sympatholytic, and anxiolytic effects. It produces volatile anesthetic, sedative, and analgesic requirements, so it can be used with other anesthetic agents because it reduces the anesthetic and analgesic requirements of other anesthetic agents without causing significant respiratory depression. Next intravenous agent is etomidate. It's a short-acting anesthetic agent. It suppresses the production of steroids from the adrenal gland. So it may be the side effect of that anesthetic agent. Um, it will not produce respiratory depression. Serious or cardiovascular stability is the main advantage over other anesthetic agents. It can cause nausea postoperatively, and its other disadvantages is that it is not good analgesic. Other adjuvants can be used along with general anesthetics like benzodiazepines, opioids. Benzodiazepines are used in conjunction with anesthetic to sedate the patient. Opioids are analgesic. They are not good amnesic. They are used together along with anesthetics. They are administered either IV, epidurally, or intrathecally. Now, what is balanced anesthesia? Balanced anesthesia is that to use specific drugs for each component. Like for sensory component, anesthetists should use nitrous oxide, opioids, and ketamine for to provide sufficient analgesia during surgery. And for cognitive components, um, anesthetists should use such agents which will produce amnesia and preferably unconsciousness. Inhaled anesthetic agents should be used for producing amnesia and unconsciousness, and IV hypnotic agent like propofol, midazolam, diazepam, thiopentone can be used for cognitive component. In cognitive component, sufficient unconscious and amnesia should be provided to the patient. And for the motor component, muscle relaxant should be used. Now, the complications of anesthesia during anesthesia, respiratory depression may occur, salivation and respiratory secretions may produce more, cardiac arrhythmias may occur, there may be fall in blood pressure, aspiration of gastric contents may occur, there may be laryngospasm and asphyxia. Patient may aware of the surroundings. Patient um, There may be a delirium and convulsion may occur. Fire and explosion of general anesthetic can also occur. After anesthesia, such complications may occur like nausea and vomiting, persistent sedation, pneumonia, organ damage like liver and kidney, nerve palsies, emergence, delirium, cognitive defects. During anesthesia, most of these complications can be cured by pre-anesthetic medications. Now, the little bit summary of the agents. These are the inhaled anesthetic agents. For halotene, blood gas partition coefficient is 2.3. It has pleasant uh, feature. It is not produced like it is not irritating, non-pungent. It can cause side effects like arrhythmias, hepatitis, hyperthermia can occur, malignant hyperthermia with the use of halothane. And fluorine has blood gas partition coefficient around about 1.9, and it is pungent gas. It can cause seizures and renal toxicity can occur with the use of this agent. Isoflurane, blood gas partition coefficient value is 1.4. It is also pungent. It is widely used. Sevoflurane, its gas partition coefficient is 0.62. It has pleasant feature. It is non-pungent. It is ideal for use as anesthetic agent. Desflurane, the blood gas partition coefficient is 0.42. It is irritant. It can cause cough. Nitrous oxide blood gas partition coefficient is 0.47. It has pleasant. It is pleasant. It does not uh, cause pungency. And the side effects of nitrous oxide is anemia, diarrhea, and hypoxia. Now the brief summary of IV anesthetic agents. Thiopentone has fast onset of action. It accumulation can occur with the use of thiopentone, giving slow recovery, so hangover effect may occur. Unwanted effects of thiopentone is that it can produce cardiovascular and respiratory depression. Thiopentone is used as induction agent. It decreases cerebral blood flow and oxygen consumption. Pain at at the site of injection may occur. Etomidate has fast onset, fairly fast recovery. Excitatory effects can occur with the use of etomidate during induction. It can cause adrenocortical suppression. It has less serious and respiratory depression effects than with thiopentol. However, injection pain at the injection site may occur. Now, the propofol has fast onset and very fast recovery. Unwanted effects with the propofol is that serious and respiratory depression may occur. There may be pain at injection site. Propofol is the most common induction agent as propofol is rapidly metabolized, so it is possible to use as continuous infusion. Injection, there may be pain at injection sites, and it has the property of anti-emetic. Now the ketamine has slow onset after effects may occur with the use of ketamine, common during recovery. After effects is that emergence reactions in which there is increase in blood pressure and certain psychotic reactions may occur. Unwanted effect is that psychomimetic effects following recovery, post-op nausea and vomiting may occur with the use of ketamine. There is increase in saliva salivation may occur. Ketamine produces good analgesia and good amnesia, and there is no pain at the injection site. Midazolam, it is a slower onset of action than the other agents because it is benzodiazepine. It has minimal serious and respiratory effects. Midazolam has little respiratory or serious depression. No pain with the use of midazolam or benzodiazepine. It has got the property of good amnesia. So this is a brief summary of the anesthetic agents. Now this is the case scenario. Uh, uh, After this, I will end the lecture. In the end, there is a case scenario. A 37-year-old male had elective arthroscopy of right shoulder at healthcare facility. Patient was induced with propofol and succinylcholine. General anesthesia was maintained with sevoflurane. After a few minutes into procedure, oxygen saturation was dropped to about 69%. Initially, bronchospasm was considered, so patient was hyperventilated, nebulized. Albuterol was administered. Saturation improved to 90s. Other concerning clinical issues encountered were development of tachycardia, hyperthermia, despite attempts to increase the minute ventilation. So patient had undergone surgery and he was induced with propofol and succinylcholine. But after a few minutes into procedure, his oxygen saturation was dropped to 69%. And so, for this, he was hyperventilated, and nebulized albuterol was used for his bronchospasm. But his oxygen saturation was improved, but there are symptoms of tachycardia and hyperthermia. Due to presence of these findings, diagnosis of malignant hyperthermia was strongly considered. For that treatment of malignant hypothermia, bentodine was administered to that patient, sevoflurane was stopped, and patient was switched over to propofol infusion. So malignant hyperthermia was associated with succinylcholine along with halothane, but it can occur with any one of the agents. Any one of the inhaled halogenated hydrocarbons. It can occur with any one of the halogenated hydrocarbons agents, most probably with inhaled anesthetic agents. So sevoflurane was stopped, and on the safer side, sevoflurane was stopped and switched over to propofol infusion. Laboratory findings include hyperkalemia, and lactic acidosis. Patient was treated with intravenous 50% dextrose, insulin, beta 2 agonist, nebulization was done, and dantrolene. Patient had adequate clinical response with resolution of tachycardia. So students, that's all. So please go through the lecture thoroughly and then do the assignment. Just don't copy paste it, please. Okay, Allah Hafiz.